Thank you for those introduction words. It's a real pleasure to be here, to have this opportunity to share our experience with you. And on behalf of my co-authors today, I would present to you the results of our study on attrition among pregnant women and non-pregnant patients initiating ART in Haiti. Let's start by a quick background. ART services and PMC services truly started to expand in Haiti in 2003, though pioneers like GazeCure and Partners in Health have provided such services a little bit earlier. This was followed by a rapid scale-up to reach all the districts in country with a pretty high level of coverage, particularly for PMTCT. Then in 2012, the country adopted the Option B Plus policy, and later the same year, in October 2012, to be exact, we start to provide lifelong treatment to all pregnant women regardless of their CD4 count. However, 2 years into the implementation of this policy, very limited data are available on retention among those patients. Hence, the objective of our study to assess the level of and factor associated with attrition among pregnant women and non-pregnant patients initiating ART following the adoption of Option B Plus in Haiti. To do that, we conduct a retrospective cohort analysis where we analyze clinical data from 17,000 patients who initiated ART between October 2012 and August 2014 at 73 health facilities throughout the country. One characteristic of those facilities was that they are using the electronic medical system called eSante, where all patients are followed longitudinally on this electronic medical record. We use the Kaplan-Meier methods and cost proportional hazard regression to assess the level of N factor associated with attrition. For this evaluation, Option B Plus was defined as ART initiation during or within 12 weeks of pregnancy. We had very limited data on breastfeeding for this cohort of patients. And attrition was defined as a 90 days lapse after a missed clinical or pharmacy dispensing appointment or any official recorded discontinuation of services. We also, and others have mentioned that, assess the impact of silence transfers on the level of attrition, meaning patients who transfer themselves without the system knowing it. What were the results? And as I mentioned, we used the survival analysis framework, and this Kaplan-Meier curve shows that at 6 months, attrition was comparable to what has been being reported elsewhere. But what happened at 12 months is that we observed that nearly 50% of Option B Plus cases had a loss to follow up. And this was 35% for men and nearly 32% for non-pregnant women. And when we compare, when we go over the entire time frame of this analysis, we realize that attrition was quite high at 41% on average, with 35% for non-pregnant women and up to 62% among pregnant women. That's a 22 months follow-up. We also adjust for standard health facility and patient factors that we will show up in the next slide. To assess factors associated with attrition, we conduct a cost proportional hazard regression. We use the cost proportional hazard regression model. And this table shows that taking in the non-pregnant women as a reference group, non-pregnant women with early stage of disease as a reference group, option B plus cases with similar characteristics has an excess of a 63% risk of attrition. This risk decreased to 32% when those option B plus cases has more advanced disease. The 32% is similar to what we observe in men with advanced disease compared to the reference group, which was the non-pregnant adult. Other risk factors included immediately studying ART after diagnosis, that is without proper adherence. We also found some protective factors like living in the same catchment areas of the health facility, having a known positive person living in the same household, or receiving pre-ART adherence counseling, or even OI prophylaxis at baseline. In country, we have 3 main electronic medical systems, and which not necessarily communicated directly to each other. So what happened is patients dropped out at one facility and showed up at another facility without one system knowing it. But fortunately, we have in-country a national HIV/AIDS case-based surveillance system where all the data from all electronic medical records are sent. So what we did, we link our eSante data to the national case-based surveillance data, and we found that 5,900 of our attrition cases on eSante match record on the national AIDS-based case surveillance system. And from those, 418, which is 7%, have a duplicated record, which indicated active engagement in healthcare, while attrition was evident in eSante. We found that this was slightly more prevalent among pregnant women, option B plus cases, than other groups, but it can only partly explain this level of attrition. We also try to analyze or to find out when the pregnant women or option B plus cases tend to fall out of treatment relative to delivery. We have by now realized that we have been placing an emphasis on pregnant women or option B plus cases. When we look at the total attrition cases that we have, and the one that have had been on ART for 12 months or more, and also have complete data on last month's period, or date of delivery, or data that allow us to estimate the time of pregnancy, we found that almost half of those attrition cases occurred during antenatal care, and another 23% occurred within 1 month of the delivery date. And when we take into account the cultural context and how the behavior of pregnant women in country, we realize that drops out occur very early. Like another presenter has mentioned, patients tend to come to ANC late during pregnancy. So we realize that dropout occurs very early. So in conclusion, we would say that attrition is higher than we expected in country, and certainly what is being reported elsewhere. Option B plus group has up to 62% higher risk of attrition compared to non-pregnant women of similar characteristics. And we also identify key modifiable risk factors that we can act on, like initiating ART immediately should come with intensive support for adherence, or initiated on treatment late in pregnancy is a risk factor. Key protective factors, as we mentioned before, pre-ART counseling, living in the same catchment area of the health facility, or OI prophylaxis at baseline. Given we have been using routine program data, we had to deal with some limitations, varying quality of data across sites. We have had certainly an overestimation of attrition due to the silent transfer phenomenon, and as all observational data, we have to account for biases and confounding factors. But however, we have been able to draw some key recommendations, and including early, sustained, and tailored intervention are definitely urgently needed in Haiti to reduce attrition, particularly among pregnant women. We need to have a concerted effort among all implementers to attract pregnant women into care early in pregnancy. And we need to ensure access to appropriate social support. 1 pill a day does not guarantee adherence or retention. We need to continue to support pregnant women. Having someone in your life talking about adherence, retention in care, increase the likelihood of this being happen. We need more than before to have intense adherence counseling, particularly when we move to test and treat, in the case of option B+, to insist on the importance of staying on medication, the benefit for the patient herself, the infant, and the partners, and more importantly, to assess risk of attrition and barrier to adherence, particularly in Haiti or in pregnant women where the cultural context dictate that pregnant women stay home for a number of days or weeks after delivery, which tend to prevent them from searching services, or for those who go in rural areas where they were looking for, they were receiving services in the cities. This can take 3 to 4 months for them to come back, and these times account for the time for them to be declared lost to follow up. And lastly, we need to be more proactive in our retention strategy, not letting pregnant women become lost to follow up, but proactively engage them to make sure they continue on with not only the medication, but coming to look for the services. Lastly, I would acknowledge the Ministry of Health for the support and the leadership, the Center for Disease Control and our colleagues from the University of Washington, and the implementing partners from which we retrieve for those data, and more importantly, the patients and that we serve, and you for taking the time to listen to this presentation. Thank you.
This paper is open for questions. These data are quite scary, actually.